20% of all gastric cancers are diagnosed at stage 4.
We went to the doctor and they thought at first it was just like acid reflux.
He did the best that he could with what he knew, and it sounded like morning sickness.
He saw 3 stomach ulcers. They were bleeding. So we thought, okay, that's obviously what is the cause of all of this.
We were waiting for a colonoscopy, which we know wouldn't have found this.
This type of cancer doesn't show up in scans.
Diffuse type gastric cancer doesn't like to show up on scans.
Unfortunately, the type of stomach cancer that I was later found out to have had is the kind of cancer that hides.
I've listened to quite a few videos of people who almost shares this very similar story.
For my biopsy, it turned out that it showed no cancer.
They took biopsies. It came back positive for H. pylori, negative for cancer.
I kept complaining, things started getting worse.
And these symptoms they mimicked other things. When you know something's wrong and you can't figure out why, it's extremely frightening.
But I don't think there is no test you can do for stomach cancer.
The diagnosis process for this type of cancer is poor. You know, like even biopsies didn't catch it. There has to be a better way eventually.
So they thought I had esophageal cancer.
It took about 9 months, and then they did find out after a misdiagnosis that I had gastric carcinoma.
During the endoscopy, they visually saw the tumor.
I, never would have thought that I would get cancer at my age.
I see a patient, 30-year-old, having heartburn. It's stress. It cannot be cancer. How can it be? You're too young for cancer.
I do have gastric cancer in my family. What the heck with not being screened earlier?
Maybe if I knew a little bit more of what the symptoms were.
We've got to do better at the H. pylori testing, and to me that goes hand in hand with the early detection.
What do we need? We need earlier screening, and I just feel we need more support groups.
So it's important to have these stories being told, because unfortunately, as I told you, it's like most of these conditions present when it's too late already.
Thank you. I'll let you clap. It is a great video. Thank you for the video. What we just heard are the voices of patients and caregivers who are living this journey every day. People who have turned their experiences into strength, support, and advocacy for others. Over the past 2 days at the Patient Empowerment Summit, we focused on something incredibly important: patient empowerment. Empowerment means learning, asking questions, connecting with others, and understanding the treatment options that exist today. But empowerment also means something else. It means using our voices and our experiences to help improve the future for the next patient who will face this disease. My name is Aki Smith, founder of Hope for Stomach Cancer, and also a caregiver. More than a decade ago, my dad was diagnosed with stomach cancer. He had so many of the known risk factors, yet his cancer was initially missed. Like many families, we found ourselves learning about this disease much later than we should have. And that experience opened my eyes to something important. For many people, stomach cancer is not diagnosed early, not because anyone did anything wrong, but because awareness, screening, and education simply hasn't caught up yet. That's why we're so grateful to welcome you to this next session, Prevention, Early Detection, and Health Equity. This conversation is about looking forward, about improving awareness, expanding research, and creating a future where more patients are diagnosed earlier and have more options. And one of the most powerful ways to start this conversation is through the voices of patients themselves. Our next speaker is someone who has turned his personal journey into advocacy and awareness for facing other people with stomach cancer. Please join me in welcoming Jason Diaz.
Excuse me. Okay. Well, thank you, Aki. I appreciate the introduction, and I think this goes without saying, but thank you for everything that you do. We all appreciate it. So yeah, like Aki said, my name is Jason Diaz. I'm a husband, a father of 2, and a stomach cancer survivor. In 2018, at 32, I was diagnosed with stomach cancer. And just like many of the stories that you're going to hear, I had symptoms for well over a year. Was seen by multiple doctors, including a trip to the urgent care. And it was the same thing. I was pushed aside as being too young. Eventually, it started to click that there was something that was going on in my body that I needed to bring to the forefront of my medical team. And even that was tough in itself, because when I finally saw my medical team, who my primary doctor, he still shunned me off as having just acid reflux. So at that moment, it was pretty much fight or flight, and I decided to fight by lying. Doctors are in the room; they don't like to hear this, but I lied. I lied as much as you could lie to try to get seen to see a specialist. At this point, Dr. Google was already my best friend. So I had been Googling symptoms of stomach cancer, colon cancer primarily. So in my mind, I already had a list of advanced symptoms that I knew would be a cause for concern if I mentioned it. And that's what I led in with. Once they were going to send me to do an H. pylori test, I had the referral in my hand, and I was about to walk out, call it divine intervention, God. Something said, don't go. Tell him about an advanced symptom that you know about. And that's what I did. And I told him I had blood in my stool. He sent me to a specialist, and at that point, a week later, I was diagnosed with stomach cancer. So when being diagnosed and at 32 at a young age, right, your whole world starts to kind of like flash. Everything starts to flash in front of your eyes. At that moment, I knew that I wanted to advocate. It was like my aha moment. Before I even knew my staging, before I knew I was going to do any type of clinical trial, I knew at that moment, my aha moment was, okay, I'm going to do whatever I can to not let anybody feel the way that I felt when I was being, basically shunned off from my symptoms that I was feeling. During this process, I actually came across a gene that was not recently discovered in 1998, but like barely came to the forefront in the late 2000s. Was CDH1. I was diagnosed with the CDH1 gene. That in itself was the reason why I developed gastric cancer. And with the CDH1 gene, it's the hereditary diffuse gastric cancer, which significantly, what's the word I'm looking for? Significantly is aggressive compared to other types of stomach cancer. Signet ring cell, I'm sure many of you have heard that, SRCC, extremely aggressive, hides well under scans. And this is a type of cancer that now I know that I carry, or I carried at the time, and I will continue to pass it on, unfortunately. So I have a 4-year-old son. His name is Jude. I have a 1-year-old daughter. Her name is Juliana. And Jude inherited the CDH1 gene. We know this for a fact. Juliana carries my wife's BRCA gene 1 mutation. We know this for a fact. So as a parent, when you hear that your children carry these genes, it becomes really overwhelming, because the fight is no longer about myself anymore. Now the fight is for them. And naturally, I think if it wasn't for that reason, I probably would have stepped away a little bit from advocating and focused more on my family. But being that now I have a direct connection again with gastric cancer, and just cancer in general, it fuels me to want to step up and fight the good fight with this early detection. Because I know about these mutations, my children will grow up with something that I didn't have. Awareness, monitoring, and access to better technology as time goes on, that we're seeing leaps and bounds of where even I was diagnosed in 2018 to where we are now in 2026. This is why early detection matters so much. Today we're entering an era where scientists are developing tools that can detect cancer even earlier than ever before. Some tests right now are being designed to detect dozens of cancers from just a single blood draw. But how do we get access to that to the community, right? How do we get that approved in the gastric world setting? And this is where advocacy becomes such a huge part in that, where funding becomes such a huge part in that. Instead of waiting for someone to get sick, we could start identifying cancers before symptoms happen. And I think we were just talking about that right now with Emmy. The goal is, we may never eliminate cancer, or we might not hit that anytime soon. But if we could identify cancer at its starting stages, it has been shown that then we could defeat cancer. We could monitor it. We could come up with a plan. We could do long-term surveillance. Ultimately, that's the end game. So, I mean, I could ramble on about myself, but the early detection matters to me the most because this now affects the people that I love the most. It's one thing for you to hear that you have cancer. It's another thing to think that your children could get cancer, because your job is to protect them as parents. Your job is to put them in a position to be more successful than what you were. And I was battling inner demons with myself when I found out that my kids had these genes, because you almost put the blame on yourself, right? It's, why did this happen? And you start questioning why you have to relive something like this again. But I have to remember, I have to be hopeful. I have to know that we have tools in plan. We have early detection acts that we're shooting for, so we could, protect not only my children, but protect your children's children, protect your loved ones and family members. And, for some of us, we've went through treatment and we're currently going through treatment. The greatest gift would be to not have anybody ever have to go through treatment. So this is why it matters to me so much. I'm here because someone kept pushing for better answers before me, for better research before me, and some of those people aren't here anymore. And I want to make sure that, I continue to push the good fight for them, as well as for, other people that are going to come after me. So my hope is that the work that's being done today ensures that the next generation, including my own children, have a better chance. So thank you very much for that. So before we begin introducing our speakers, I just want to first take the time to thank our Advocacy Day partners. We should have a slide that comes up, I believe, with them. We just appreciate everything that you're doing to ensure that this is going to be a successful event. Partnership is huge, especially with an organization that's as small and boots on the ground like Hope for Stomach Cancer. The more partnerships we get, the more obviously funding we get to have events like this, and also the more participation that we're able to go and offer scholarships and bring people in here that want to go and make a difference. So I just want to thank the sponsors for that. All right, can I get Dr. Oh, do I have the slide? No, right? Oh, the little clicker? Okay. I guess I did. I had no one told me this was up there. I'm like pointing back there to go. Okay. All right. So for our first presentation for today, I want to welcome up again Dr. Jeremy Davis to the podium. He's going to be presenting the treatment story with prevention and the early pipeline. And as a reminder, all Q&As will happen after he's. Were you in Q&A with you right now? Okay. I think it's after. I think it's towards the end. Okay, so towards the end, when we do Q&As, please just remember to raise your hand and wait for the microphone. Okay.
Is this your phone?
It is. You can have it if you want.
No. Not unless the Apple Pay is unlocked. Okay, it's a pleasure to be back up here. Before I get started, I just want to say again, and this is a little off script because I'm supposed to talk about prevention in the early pipeline, but in that video was Lissa Canavan, and then I'm thinking about what your story, thinking about Chul and her mom. You have to advocate for yourself. I know it sucks to have to do that. And it seems like, why do I need to know more than my doctor? But it's that way. You know what? That's the way it is. You have to advocate for yourself, okay? And I've been face to face with people like Lissa, and as a physician. Maybe if I wasn't as tough as I am, maybe it would be hard to have a patient maybe challenge you, but I don't know. I mean, listen, at the end of the day, it's your body, it's your life, right? And, to feel like, oh, am I offending the doctor? Who cares? Who cares? right? You know, I also tell my patients, you know, like let's say you go to a doctor, they give you an answer and you're like, man, that doesn't sound right. Maybe I need to go get a second opinion. Well, but I don't want to offend that doctor. Who cares, right? If you offend that doctor because you go get a second opinion, then they shouldn't be your doctor, right? Because, no, seriously, I think, you know, the sad truth is not everybody's going to have the answer. Not everybody's going to know what we think they need to know. And so, again, when you are, you know, striking out or you're not getting where you need, just go somewhere else, okay? So do that for yourself and you'll be all right. Okay, I'm going to just show a few slides. You guys are probably ready to go to sleep anyway. No? Okay. Oh, Cora said no. Okay, Cora, if I see you dozing over there, I'm going to throw something at you. Okay, so I just want to go through a few things, but I'm really going to end with hopefully a message of hope. You guys, we've already talked about this probably yesterday and a little bit this morning, but I just want to go through the trials pipeline, but really just to kind of paint a picture. The Claudin 18 stuff, right? You know, think about where we are now, right? When Claudin 18 was kind of identified, you know, really now we have like lots of potential options, right? It's not just the way you attack the Claudin 18, right? Or knowing about it, it's the way you attack it, right? Is it a monoclonal antibody? Do you develop a T cell that's genetically modified to attack it? Do you combine it, you know, this antibody drug conjugate, right? Again, all of these things are born out of research. Now the challenge is, right, if you come to my office and I say, okay, let's look at your tumor, and it doesn't express Claudin 18, then you know what you do with this? You just put it to the side, you know, and that's just the way it is, right? I go to a store and I look for, you know, certain clothes. They don't have the stuff that fits me. I got to go to the other store. So CAR T cell therapy, just so you guys know, CAR T is very exciting. We're trying to figure out how to apply it to more cancers. So just to give you an example, about 20 years ago, I worked at the National Cancer Institute as a fellow, and we were trying to develop CAR T cells for a type of brain cancer. And at that time, it was really, we were unsure how many cancers we could apply this to. And I would say over 20 years, we're still struggling a little bit to figure out how to apply these, but more and more people are able and willing to try this these days. It's labor intensive, and I showed this diagram because I think it tells you a little bit about what you have to do, right? We have to take the white blood cells out of somebody's body, so this is called an apheresis, okay? And then what we have to do in the laboratory is genetically modify the T cells, which are a kind of white blood cell, to express this specific molecule that we call a CAR, C-A-R, and it stands for chimeric antigen receptor. And then what we do is we grow up those cells. Geez, I keep hitting the mic. I'm Italian. So we grow up, no, I'm not. We grow up those cells to a huge amount and give them back to the person through an IV. And then those cells are supposed to go throughout the body and recognize the target, in this case, Claudin 18, but you could imagine it could be other targets. And over the years, we've tried to design CAR T cells to target a lot of different kinds of molecules on different cancers. So again, the technology is there. The question is can we find the right target? So it's not that we can't genetically modify T cells, right? You know, I could teach you how to do this in a laboratory at a high school probably. The challenge is identifying the target, okay? I'm not going to talk about this much. You know, there's lots of changes in tumor cells that are shared across tumor types. FGFR2 is one of those. It's not unique to stomach cancer. We can see this overexpression or fusion proteins in other cancer types. But again, it's this kind of, is it something that somebody wants to work towards? Can we make a drug that targets it and is effective, right? What I'm really excited about and what you guys should probably hear a lot more about in the coming years is this tumor microenvironment. And what that means is that, and I think the picture shows this a little bit, is that tumors don't just live by themselves, right? Tumors are in your body. They're intimate with the rest of your body. So there are other components that are there with it, right? Not just tumor cells, but blood vessels and immune cells. And those immune cells are the ones that we're trying to activate when we give drugs like pembrolizumab or Keytruda or nivolumab or Opdivo, right? All we're doing with those drugs is trying to kind of, get those immune cells activated and killing cancer. But the truth of the matter is, that's a very simplistic approach. And by the way, we've been trying to do this for decades. And sometimes it works, and sometimes it doesn't. And as you guys know, Ipi, Nivo, those kinds of drugs, Keytruda, they don't work all the time, okay? So what people are trying to do now is try to figure out what are the other things going on in and around that tumor where we can stimulate the immune system, or we can take an immune system that's not too hot and make it hot, okay? And some examples here in gastric cancer, CCR8 antibodies, where essentially we're trying to take immune cells that kind of suppress the immune response and try to activate them. You guys will see a lot more about this over the years, or in the coming years, okay? Yes, Claudin 18 is out there, and people are going to kind of, they're going to ride that as hard as they can, right? But Claudin 18 is only going to be useful for a subset of patients. What else is there? What I really want to talk about just for a few minutes, and then we'll move on to something more exciting, is prevention, right? So to Jason's point, right? I'm a surgeon. I've taken out a lot of stomachs in my day, and it's not something that I'm often proud of because of the consequences that it has, right? But what do I do if I can't just prevent stomach cancer by taking out a stomach, at least as it relates to CDH1, right? How can we find cancer early and prevent it? And what I've told Jason, right, is that my goal is that when his son is 14 years old, that he doesn't have to worry about getting his stomach removed preventatively, or he doesn't have to worry about getting stomach cancer because we've figured it out, okay? So how are we going to do this? So just a little bit of the science, okay? The point with this slide, other than some pretty pictures, is that for a lot of cancers, there's something that kind of starts the process, right? It's the spark that lights the fuse, right? It's that initiating event. And for people born with a CDH1 mutation, it's this CDH1 mutation that they're born with. And then at some point, that other normal copy of CDH1 that you have, right? So Jason's got 2 copies of CDH1. One has a misread, right? That's the mutated copy, and the other one's the normal copy. But at some point in the stomach, that normal copy ceases to exist. It gets silenced. It also gets lost or gets mutated, right? And that's the initiating event. And what happens in the figure down on the bottom right, the thing that looks like the circle, the 3 circles in a row, is that loss of CDH1 causes these cells, when they divide, to kind of divide awkwardly. So instead of dividing this way, they divide this way, and all of a sudden, you get the growth of these signet ring cells. So that's like the spark lighting the fuse, okay? Well, now that fuse is going to burn. The question is, we don't know how long. For Jason, it burned for, a couple decades until he was in his late 20s, early 30s, right? So these signet ring cells form, but what can I learn about the transformation of those signet ring cells into advanced cancer, okay? What can we learn about them to help us understand cancer prevention? So I just want to show you how the science goes into, translating into humans. What this shows is we take all the cells from somebody with CDH1 in their stomach, right? So let's say I took out somebody's stomach with CDH1. I did a prophylactic gastrectomy. I took a bunch of those stomach cells and mashed them all up in a test tube, and then put them through a machine, and we sequence all these cells, right? So every cell that we sequence has a specific signature. And what we see in the middle, where the arrow is pointing, is those signet ring cells kind of all clumped together, but they're not all exactly the same. all of those signet ring cells are not all exactly the same, even though they all formed because of the CDH1 mutation. And there's a little bit of heterogeneity, right? They're a little different, okay? So we start to dive into that. What's making them different? Why are they different? All of that stuff, right? And so then what we find out is that we can really dive deep into those signet ring cells. And, you know, there are 18,000 genes, right? And so how do I know which one's which and what matters or whatever? But this is why people get paid big bucks to look at this stuff, right? So long story short, we start to dive into some of these gene signatures where we say, hey, some of these molecules, they mean something, right? Why are we seeing these in the context of these signet ring cells? And the only reason I show this is because it starts to paint a picture. And what it did for us is it started to paint a picture to say the immune system is already activated even when these very earliest cancer cells form, okay? We know that's true when somebody has advanced cancer, the immune system is activated. But I don't know if we always knew that the immune system was activated at the earliest stages of cancer development. So this research fellow, Ben Green, in my lab, looked at this stuff, and all I'm trying to show here is if we look at all the different kinds of white blood cells, T cells, B cells, there are these things called NK cells, natural killer cells. Sounds like a nickname. You're a natural killer, you know. But NK cells. The point is, yeah, there you go. Hey. I hit that mic all the time. The point is these were changes that we were seeing in the very earliest cancer cells that form as the result of this CDH1 mutation. So it starts to say to us, wait a minute, where do we, guys, by the way, where do we use Keytruda these days, or nivolumab, or, right, in patients with advanced gastric cancer? Durvalumab now we're using in the perioperative setting. But the point is we're activating the immune system kind of late in the disease right now. So now we're getting some insight, well, wait a minute, the immune system's active early on, but it's clearly not killing those signet ring cells, right? It's there, the immune system's there, but it's not killing the signet ring cells. Why not, right? So my point of showing this is that this ultimately makes us say, yes, can we use nivolumab, can we use Keytruda, can we use durvalumab in the advanced cancer setting? Yes, but maybe, just maybe, we can use the immune system or harness the immune system to fight precancer, right, or the earliest forms of cancer. But how do we do that, right? That's the research that I do in my lab. But the point is that you can see that we're moving or trying to move that needle from focusing on treating advanced cancer, right, to treating earlier stage cancer. The other thing I want to bring up is some of the work that I do with my colleague Perry Guilford. So everybody's alluded to 1998 is when CDH1. Well, that's when Perry wrote his paper in 1998 that describes CDH1 as being associated or the cause of hereditary diffuse gastric cancer. So what Perry is trying to do is identify targets, again, very early targets in the formation of diffuse gastric cancer, right? And so the whole point of this slide is to say that he uses this model called organoids, where they basically took mouse, like CDH1 deficient mouse gastric cancer cells, put them in a dish, and then we treat them with various drugs. And what he showed is that if we target this pathway, or this molecule called AKT, and the pathway that AKT activates, that we can kill these early cancer cells, right? So the idea is that we can give some of these drugs. Obviously, we don't want them to be toxic, but we could give these drugs to people with a CDH1 mutation or some other population that's at high risk for stomach cancer and prevent those earliest cancer cells from ever forming. Now, Perry's done this in cells in a dish and in mice. We want to put this into patients. This is the one I told you about earlier. Do you remember how much it would cost me to run 20 patients in a clinical trial? $500,000. Anybody want to write a check? I mean, that's the challenge, right? Now, here's the other truth is we can run the trial. It can cost $500,000, and it may not work, right? My guess is, though, it would give us more information. We'd generate more data. We'd understand maybe why it didn't work or why it did work, right? But this is where we're headed, right? Because when Jude is 18 and old enough to, know what's going on, or at least old enough to vote and buy cigarettes or whatever, wait for the day, right? So, right, we want to be in this place where we can say, you know what, you've got the CDH1 mutation. We're sorry you have it, but guess what? We've got a solution for you, right? And I don't have to take out your stomach, thank God. Okay? So all the stuff I talked about earlier, right? That's the stuff that's in clinical trials right now. But remember, I showed you that timeline. How long did it take us to get to Claudin 18.2 clinical trials? Over 10 years, right? So all I'm doing by showing you this is turning the clock back, right? I don't want it to take us 10 to 15 years to get this into clinical trials, right? But what are some of my barriers? Cost, right? Funding, right? Okay, my summary slide. And I have 5 minutes left, by the way. Can we use CDH1 to help us understand early gastric cancer development? Yes, that's why I do what I do, right? Like, I care about stomach cancer, right? I have to find a way to study it, though, right? So I chose not to study H. pylori. I don't know, maybe because there's a lot of people that study H. pylori, right? So I'm using CDH1 and the CDH1 mutation as a way to help me understand stomach cancer better, right? And then find a way to treat it. That's not everybody's approach, right? Everybody approaches their research differently. I think we're going to be able to prevent diffuse gastric cancer, at least related to CDH1, with some sort of targeted therapy, whether it's AKT, which is what Perry wants to do, or some sort of immunotherapy or some combination. But the idea that we will be able to prevent stomach cancer in people who are at high risk due to mutations like CDH1, or many of you may know of CTNNA1, etc. Okay? I want to run these trials in the next few years. I don't want to wait 10 years. But again, it costs money, and that's the sad truth, right? But the last part is, and this goes back to what Jason talked about, partnering with you all, partnering with patients and advocates in these cancer prevention and early detection trials or research is critical. But not just so that, you sit in a room and, contribute that way, but it's that other part. It's that advocacy of talking to your local physicians, knocking on the doors of your local, academic medical centers, doing the advocacy on Capitol Hill, right? Anytime you have the opportunity to stand up for yourself or for people like you or for your family, right, do it, right? You have to find something in your life to be passionate about, right? I don't know, there are people out there that are passionate about, skydiving or, pottery or whatever. That's okay. But just find something to be passionate about. I don't care what it is, but find it. And then once you find that thing, then you pursue it, right? And you don't look back. You don't regret it. You just go after it, okay? And you're doing that. Keep doing that. Thank you.
Let me adjust this. All right, thank you, Dr. Davis, again, for spending the day with us. We really appreciate you being here. Okay, perfect. All right, for our science liaison update, Dr. George Laliotis will be presenting on bridging the gap, leveraging genetic testing to improve gastric cancer prevention. So please welcome Dr. Laliotis up.
Hi, everyone. I hope you're not so sleepy. I needed to have like 4 coffees. I'm also European, so I need espressos. So these are, yeah. I'll try my best. So I have 20 minutes. Let's get going. So I'll give you an overview as we said in the morning and yesterday, we talked about management and treatment, what you do when you have the unfortunate news. But now we'll go a couple of steps back. So what is kind of the high-risk features that like families and people just before being patients, they have to look for, what tools we have, and we will talk about some things that Natera also have to help you actually find way earlier, maybe how this can be managed. So that's me. Let's move over. So what we'll cover today. So we're going to have a bunch of slides showing you what is the profile of people that may have high risk for hereditary cancer and why this is very important, both for management, outcomes, and general for the family itself. Some specific tools and tests that can help you identify those germline variants, and we will discuss about this. And what some specific programs that are in place that families and patients they can actually utilize to support their care. So, how often is cancer hereditary? So, you see on the left you see a pie chart. This is how it's called, and you see three big categories. The first one is sporadic. So, basically, you have sporadic is the general population of patients that they have breast, gastric, lung, colorectal cancer with some very, very minimal, genetic background. Now we know more and more that genes play a very important role even in sporadic. Then we have the second tier, the familial, which is not a specific genes that drives cancer, but is kind of a set of specific, single nucleotide polymorphism or specific changes in genes that they go from family to family. Common way of eating food, traditions that maybe they also lead to familial cancer. And you see a 5 to 10% which is hereditary. It's specific genes that we know them by name and by specific mutation that A changes to G, C changes to G. We know specifically, we have tracked them over time with science, and this leads to 5 to 10%. So why this is important? As many of you and Jason mentioned, his story and many other people, I learned so many things the last 2 days. They shared their story on hereditary cancer. Yes, maybe just an alteration on a single gene, but you see here on the right how greater it can be the risk of specific tumors, including gastric. You see if you harbor BRCA1 hereditary mutations, how up to 60% higher risk of breast cancer. The same for uterine, and unfortunately for GI tumor, colorectal and gastric, up to 100% if you have the APC genes, which is part of the Lynch syndrome as well. So, what are the red flags for hereditary cancer? What people should look for? Basically, cancer diagnosed younger than the expected age. Based on the 2026, cancer statistics. The median age was around 47 years old. Now we see, unfortunately, going younger and younger. So if you have like a family history of around in the 20s, this is a major red flag. To have also multiple primary cancers in the same individual, as many patients share their stories, you can have increased risk for breast, for colorectal, for gastric across the board. If you have bilateral disease, meaning in both sides of your body, usually the majority of the times the tumors, either testicular or breast, they actually grow in one side. So this is another thing to look for. Some other things is rare cancer, some neuroendocrine in nature, or some different, differentiation of cells. This is also a red flag. And one of the major that, this is one of the main questions that physicians can have is the multiple family members on the same side of the family. And there are also some specific genes that they have specific patterns. For example, the ratios from males to females, that's why some physicians are going to ask, how about your grandfather? How about your grandmother? Because there's specific, patterns of how these genes, they go from generation to generation. Now, we've said all of this didactic, why this is important. The purpose even of this summit and many other things is just for you to understand that knowledge is power. The more we know, the more you know as patients is actually the best thing is to manage forward. So not only from the obvious thing, which is actually to screen, to find the cancer early, because unfortunately these genes will lead to cancer development. So the easiest thing is, to find it early, to treat it early. You see the initiatives that Dr. Davis discussed before, what you can have prophylactic gastrectomy, what type of immunotherapy or targeted treatment you can have. That's one important component. And this leads basically to risk reduction. What opportunities you can have to have prophylactic medications. And the third thing, the therapeutics, what type of clinical trials you can qualify for, what research we can find out. In the previous session, we discussed about that VUS, variants of unknown significance, because now they are less than 1% of the general population, but more research we do, this unknown significance, because it's being magnified by the plethora of data that we may have, and one day, very soon, this unknown significance is going to lead to a very known mechanism that we know how to treat and actually manage. And something that's very important on Pillar 4 is the management of the family. Jason shared his story about how he worries about his kids now, and this is something that all the patients should think about, that these diseases is not only for yourself, is across the board of your burden for your family. So these are some indications. I'm going to keep it very high level. These are some of the examples in the upper GI space, including gastric, something that indications that genetics are very important in hereditary cancer, and they actually affect the communities. So you see one of the examples of gastric is the diffuse gastric cancer that we discussed in detail, and also in the aspect of Lynch syndrome, which is less than 3 is actually 3 to 5% of gastric tumors. This is something that affects the pathophysiology and the prevalence of gastric tumors as well. And here I have some more information about the specific genes. It's not only CDH1, it's also a big family of, you see some genes that are called ATM, BRCA1, BRCA2. These are in the family of genes that actually check for damages in your DNA, as basically because the cells proliferate, so you generate new cells, old cells, they actually die, and we try to make sure that your DNA that goes from the old cells to the new cells is actually spot checked, that everything is fine. And many times, some of these genes that they check that everything is fine, they're not working very well, and some mutations, they're just being accumulated, and this is how, actually cancer can be created. And this is some of the many common mutations that are known to be predisposing for gastric cancer patients specifically. Now, so one thing is, people in their mind, they say hereditary cancer is pretty rare, basically. But I have here some 3 large studies. You see 45,000 patients, more than 200 patients, 20,000 patients of some studies that they actually shown very clearly, and now these studies are being commented also in the NCCN guidelines, that these hereditary cancer syndromes are actually way more common than what we think. You see, for example, for me very important is the middle study, where they have more than 200,000 patients, where they had carriers that it was 0.3%, although the literature says that it's way, way less. And the majority of them, 63% of them, they had no documentation in their electronic health records that this is something that was actually happening. So this is more like to raise awareness, and always to have in mind that to look for those symptoms that we said before. And also everyone as physicians and scientific community, we actually need to do better to document all of those things, because there are solutions, there are programs that these patients they can participate in. So now we will go more on how to detect things, more like, as I said, as a technology, what are the screening options that you have, and also I have a slide or two on how we had the section about Signatera, how also some solutions that we have in Natera can also help across the board. So Natera and many other companies, they have actually a very comprehensive screening panel that you see here. This can include specifically so the blue ones that you see for breast cancer, for Lynch syndrome, and GYN malignancies are super specialized. Basically, if you have a high, for example, if the physician has in their mind, most likely this is hereditary breast cancer, they're going to order a specific panel of genes. If you go towards the right, on the green ones, they're also available pan-cancer and comprehensive gene panels that basically you can plug and play. You can have a plethora, a complete list of genes that they can be tested, and it can be informative across, solid tumors, not only in colorectal and gastric tumors, but across the board. And all of these can actually be ordered by anyone, a genetic, a GC, a nurse, an oncologist, like everyone. So these are the solutions that are available for everyone. And recently, actually a couple of months ago, I'm showing this slide that we got an approval, and now Natera is actually providing a very comprehensive gene panel of more than almost 200 genes that basically can be across for more than is actually 14 solid tumors that it can cover across the board. So it's a very comprehensive way that actually you can see for germline variants, and you can detect actually cancer and know if you have elevated cancer risk or more. So this is where what I was saying before. So we discussed yesterday and this morning a little bit about Signatera, which is the way that you can detect ctDNA, circulated tumor DNA, and which is basically sequencing from the tumor. Then you have the option of Altera, where it can help you find the biomarkers that we've been discussing about Claudin 18, HER2, PD-L1 status, some other fusions, some other rare fusions as we discussed. And the third, that is actually, you see how comprehensive it can be, the product that the patients can have access, is called Empower. This Empower test actually includes those 200 genes that we mentioned before. So this is a combination of sequencing on DNA and RNA, because you need like an extensive coverage to see all of these 200 genes. And you see across the board, and I will go to the next one, this is kind of, we offer combo ordering, basically patient, and it can be funnel of patients either starting from Empowering. So you get Empower, you get the news that you may harbor one of those mutations, and eventually, if a malignancy is going to be developed, then automatically you can have access from the same tissue to have information about ctDNA and for biomarkers. And on the contrary, if you have, for example, a diagnosis and you get ctDNA and genomic biomarkers through Altera, you can actually assess both for yourself, and of course you can have another sample for your family. So basically this is kind of a way that across the spectrum of care, the patients, the nurses, the oncologists, they can have information back and forth. And the good thing is that you have basically, because the way that these things are being ordered and reported, and many of you, they raised some question either in the Q&A session and separately when we're discussing one-on-one, all of this information are readily available not only for you and your family, also for the physicians, everyone that you're actually going to discuss about your care. So having said that, you see me here bragging about all of these great assays and, cool science, but the point is there are a bunch of, and I'm including a couple of studies here, that although these technologies are readily available, you see they're basically strictly on the guidelines. There are actually important percentage of patients with colorectal and gastric, that you see on the left, and pancreatic cancer patients, that basically these tests are being underutilized because there's not actually the message out there of when someone to be tested, what needs to be included, what should be the reporting, what should be the list of genes. So we're having this discussion mainly for awareness. These are two really big studies that they have, you see more than 1 million patients there. So this is kind of clearly saying the technology is moving, but the awareness is not that solid. So this is another way for us to raise awareness. Now, why this is important? So we have internally in Natera and many other genetic companies, actually, let's have the scenario that someone gets Empower, you have the results that you have a specific pathologic variance, what you can do next. So the number one is, as we said, automatically we trigger to do the same testing automatically in family members. So it's not only on yourself. We can order with the same, actually free of charge, with the panel testing for your family. So that's the first one. The second one, as we said, when you have the Empower testing, you can also order Signatera and Altera and have a comprehensive view, not only for the hereditary cancer genes, also for specific, for ctDNA and specific biomarkers. And the third one, well, I will show you some slides, that basically when we have, when you do the Empower, automatically you trigger both the patient, their family, and their oncologist actually to test ctDNA and these biomarkers automatically. So that's the first one that I was talking to you about the family testing program. So when someone gets the results from Empower and you have a pathologic variant for a specific hereditary cancer, automatically we trigger within 180 days, 60 days, we offer free complementary testing for for exactly the same panel for all the family members, actually kids and family of the patient that received the results. So this is kind of very quickly to find out if the same genes that they were altered and we found it in your DNA is also passed over to your family members. That's the first program that we have. I would like to mention that something that is important, that although the coverage, the technological coverage for these technologies, they cover the majority of the cases, there's still 10% chance that some of these genes maybe are not going to be discovered. So there is another set of tests that they can be actually utilized. And that's why I mention it, because in many cases, we see that also ASCO, the American Society of Clinical Oncology, recommends that they have to be done, these tests, independent if these 10% of the cases will be actually lost. So this is, although 10% are going to be lost, we can still get a lot of valuable information both for the patients and the family. And I will pause here and maybe expand. I'm also on time, so I will do it very quickly. So as we said, when you actually trigger and get the pathologic variants, automatically all the patients, we offer them free Signatera in this setting. So this is another way where we try to integrate everything, basically to have the genetic testing, the biomarker, and ctDNA. And also, we offer Signatera in the entire setting, as we said, for eligible patients and their family. So, in the last slide, I promise, why this is important. We also published this data actually a couple of months ago. So we did the pilot testing of, as we said, you do the Empower, you get the bad results about the gene, and we kind of, we alert the families, and we start also Signatera testing earlier. And you see across the board, if you compare the blue with the green, this alert, the early alert program, actually led to catching many cancers earlier and providing actually better care for the families. So this is kind of a pilot study with 120 clinics. We're still expanding to show, because everybody is going to ask, okay, you trigger all of these things, the extra testing to the family, so what? So we actually show that if you trigger that testing to the family earlier, is way more likely, basically, to find cancer in an earlier stage and basically improve outcomes. I try to do things very quickly. That's a summary of what we discussed today, that basically finding the genetic risk early is the best way to prevent things, to find things as early as possible. And the second thing is not only for the patient, it's also very important for the family. So that's why we're pushing not only for the information about the patients, but also for the families if they are in higher risk of some of those hereditary cancer. And third, we also provide, and these materials will be available to you, that if one person gets available with positive results, their entire family will get access to all of this information and help them plan all their testing programs and their care going forward. I think that's the last slide. Thank you so much.
And thank you again, Dr. Laliotis, for spending the weekend with us. We really do appreciate it. Next, I'd like to introduce Dr. Chul Hyun, who will be sharing his experience in stomach cancer prevention in high-risk U.S. populations. Dr. Hyun is a gastroenterologist at Yale School of Medicine and the director of Gastric Cancer Prevention and Screening Program, the first academic program of its kind in the United States. His work focuses on prevention, early detection, and reducing disparities through communities based on migration-informed risk strategies. He leads the Gastric Cancer Prevention Lab, integrating clinical research, implementation science, and policy to improve outcomes for immigrant and other high-risk populations. Dr. Hyun received his BS from Johns Hopkins University and his MD from the University of Miami. He completed training in internal medicine at Georgetown University and a fellowship at Yale. He also holds a PhD from the University of Rochester and an MPH from Columbia University. He also completed his postdoctoral training at the University of Chicago. A lot of experience here, guys. A lot of experience. He is the founder of the Stomach Cancer Task Force. Thank you, Doctor, for being here.
Hello, everyone. It's great to be here. Actually, this is my second time. I was here about 2 years ago and spoke at the same session, actually. And we are holding the Stomach Cancer Task Force Forum, Congressional Forum, tomorrow at 12 o'clock at the Canon 240, I think. And so I think I will see you, many of you, hopefully, because we'll have other speakers in addition to me. So we'll really look forward to it. So I have actually been in private practice as a gastroenterologist for about 30 years and practice in New York City and New Jersey. And I started to see over these 30 years, I probably diagnosed over 150 cases of gastric cancer. So many patients presenting at the late stage. And so about 5 years ago, I decided that maybe, I should go back to school and create a program where we can focus on the prevention and the screening or early detection. And this is really what led me actually to go back to school. And we've been doing a fair amount of interesting research, and some of which I think I will share with you. We already heard the two excellent presentations, mostly from the hereditary cancer and the genetic perspectives. My talk is going to be a little different. It's going to complement to, I think, what has been presented in the past 40 minutes, in that, as you know, majority of the gastric cancers are non-hereditary. And I'm sure some of those non-hereditary cancers that we understand probably may turn out to be hereditary in the future. But at this point, majority of the gastric cancers are non-hereditary. They are infection, they are environment related, and therefore it's very important to really identify those infections and the populations at risk. Go back. So this is what I call the U.S. paradox. If you look at the overall instance of gastric cancer, like we talk about age-adjusted rate, instance of cancer, it's like about less than 5 per 100,000. It's very low. But if you really take a look at it very carefully and disaggregate the statistics, you will see actually the gastric cancer instance in certain ethnic racial populations is very high, as I will show. So this is the important, high instance of gastric cancer in these populations, sort of like a hidden behind the curtain of the national statistics. My job is to bring up those disaggregated data and show, what we can do. So the high-risk groups are hidden in really in national averages that we already know, and there's no targeted population screening framework, even for the high-risk populations, in the United States. Unlike some other countries that, for example, South Korea and Japan, where do have a screening framework, and as a result, many cancers are diagnosed late with a very poor survival. So I don't think I need to go through the hereditary cancer, but the individual risk factor-wise, we already heard a little bit about the Helicobacter pylori infection, which is, since 1994, WHO designated group 1 carcinogen for stomach cancer. So this is a very important infection that I think, especially in a high-risk population, that we need to rule out. And there are many pre-malignant gastric cancer, lesions, such as atrophic gastritis and gastric intestinal metaplasia. The racial ethnic populations-wise, the Asian Americans, especially Koreans, Japanese, Chinese, and Vietnamese, actually a very high instance of gastric cancer. Hispanic, Latino populations also have a pretty high, gastric cancer instance, and the Eastern European origin populations also belong to this group. This is showing the in y-axis the instance of gastric cancer per 100,000, and x-axis being age group. So this is the data on the age specific instance of gastric cancer. So of course, as we get older, the instance of gastric cancer, just like any other cancer, increases, and that is just the biology of a cancer. But you can see that there's a significant difference between the ethnic groups. For example, at the bottom you will see in the blue, that's a non-Hispanic whites. So if you look at, for example, the age 50 or 60 actually, in non-Hispanic white, the instance of gastric cancer is probably about 5, as compared to, anywhere, 5 times of that or 10 times of that in the Asian subgroups. So if you look at the ages 70 and greater, you can see that, especially in the Korean population, is extremely high. It's over 120 cases per 100,000, as compared to, less than, probably about 18 or 17 in 100,000 in non-Hispanic whites. So there's a significant difference. One way to study this plot is to actually plot this in a little differently to what we call like a semi-log plot, where you can put the y-axis as a logarithmic plot. You will see that these 5 lines will actually become very parallel, except that those with a high instance will be on the top, and then less so coming down, and the non-Hispanic white will be at the bottom. They will have a very slow, very, very same slopes. So, speaking of the biology of cancer, yes, they all increase at a very similar rate as we get older, but they take off from different point. So, such that, for example, in the Asian groups, it will start to show a significant instance from age 40 and 50, whereas it will not be the same in the non-Hispanic white groups until they reach, for example, age 70. For example, if we all live to 120 years old, I'm sure we will probably start screening at age 70, and we have no problem actually implementing such a strategy in this country. But that is not the reality, right? But there is a significant difference between the ethnicities that you can see here in this. Now, this is another study that we did and published in the Journal of Clinical Oncology last year. So most of the data, epidemiologic data on gastric cancer, actually come from the national data or from California data. So California has a very excellent data in different ethnicities. But people really haven't looked into different states, various states in the United States. So we used the SEER data, 22, which were basically data accumulated on gastric cancer instances between 2010 and 2021. And we picked about 7 states that actually have a very diverse population, the high populations of Hispanics and Asian populations. Well, I included Connecticut there, actually. And so we included California, Georgia, New Jersey, New Mexico, New York, and Texas. And I think the recurring theme in our talks today and tomorrow will be that gastric cancer instance is found very late. How can we diagnose this early enough so that we can increase the survival, right? Because if you see these localized, regional, and distant stages, you can see that, the survival rate, we're talking 5-year relative survival rate, are significantly different from one from another. For example, if people have distant, metastatic disease, you can see that the average survival rate in 5 years is probably less than 5%. Whereas if it's found a little early, for example, localized disease, it can go up to about 70%. So now you may be surprised looking at all the average where I actually have a yellow highlighted. The average is about 5%. So you may be asking question, wait a minute, the American College of Gastroenterology showed that gastric cancer survival 5 years is about 39%. What do you mean it's only 25% in these 7 states? Well, it's because I am only showing for non-cardia gastric cancer cases. So the ACG, the ACS, American Cancer Society data is showing the survival rate for all gastric cancers, which includes not only adenocarcinomas, but also like lymphomas, and there are a lot of neuroendocrine tumors and all other cancers that actually have a pretty favorable, significantly better, more favorable outcomes than adenocarcinomas. We only picked here the non-cardia adenocarcinomas, which is actually about 70% of the total gastric cancers. By the way, whether it's a non-cardia or cardia, they're both actually very poor survival. But I'm just showing the non-cardia gastric cancer data here, and the survival rate here is very dismal at 25%. But we also noticed here, for example, the significant changes, the differences between the states. For example, for New York State, the survival rate is about 33%, whereas in New Mexico, it's not even 20%. So there's a significant differences between the states. And California, with a lot of work in California, it's only 25%, the 5-year survival rate. So I think this is showing that not only there is racial differences, but there's a significant interstate, state-to-state differences in the outcomes of these cancers. And there must be many reasons for this. We're not ready to go into that in this talk, but I'm just trying to show a data figure that you may find it interesting. The good news is that gastric cancer is a preventable cancer. Right? It's a disease that if discovered early enough, it can be treated 100%, almost 100%, if it's found very early. Interesting, because 30 years ago when I opened my practice in New York and I started to see patients, majority of, just about, maybe 80-90% of all my patients presented very late, to stage 3 or 4. But in past 10 years, I started to see a lot of people presenting, stage 1 and very early, so that we can actually remove with endoscopic procedures called endoscopic submucosal dissection. So I think we're doing better, but I think we can do a lot better, and I think it should be everywhere in the States, not only in the certain, metropolitan areas. H. pylori, as I mentioned, is an important infection. It's a cause of gastric cancer in many cases. This is something we can discover and eradicate, thereby eliminating an important source of gastric cancer, cause of gastric cancer. In certain populations, in certain age groups, I think we can do the endoscopic screening, and this is something that we're working on, and how we can make a guideline on this actually in our gastroenterologic societies. So there must be some sort of like a risk-based prevention strategies that we must develop, and that's actually where my research is. One area that where we can actually start doing research is a community. And that's actually what I have been doing in the past 20 years. because this is where, the average people are, and this is where, because if you look at the people in the hospital and the hospital data, there are people who are sick and who go to the hospital, get hospitalized, but we really don't have a lot of data from community. So if you look at the research, for example, in this area, majority of the data come from the hospital data and retrospective data. So it's a big, big data, that's fine, but, these are all coming from the patients who have been hospitalized and who have gone through the hospitalizations, not from the people who are walking around on the street. So the community data is very important. Let me give you an example of the data that we have. This is a study that we did, actually it's ongoing research in the New York, Connecticut, and New Jersey area, which we want to expand throughout the United States. So we had about 500, actually this is from the Korean population, 500 people aged 40 and above, actually. And we took the survey and asked questions if they have had H. pylori infection and if they currently have infection. So we offered the free urea breath testing, and that is to determine if they are currently infected with H. pylori infection or not. And this is the result we got here. For example, the blue shows the current infection, and the orange shows the lifetime infection. So if you look at, for example, the age group 50 to 59, you can see over 60% of the people actually have had this infection. That is basically the prevalence of the infection, you can say, a lifetime prevalence. Whereas if you look at the blue one in age group 50-59, you will see very close to about 28% of the people are currently infected with this bacteria. So these are people who are subjected to immediate eradication of this bacteria, thereby hopefully to lessen the chance of developing gastric cancer. So overall, in this population, there was about 50% lifetime prevalence of H. pylori and about 18% the current infection rate, which I think is very significant, right? Of course, these numbers will be a little less in Hispanic populations and even less in non-Hispanic white. But in certain ethnic populations, numbers can be this high. And we say something like this, should we advocate for H. pylori screening in certain population? And my answer is yes. I don't know about yours. So what needs to change? I think we need to recognize the high-risk populations. I think we should have a better access to Helicobacter pylori testing and also endoscopy in certain populations. Community education, outreach, research focused on high-risk groups, and there should be some national attention to these health disparities arising from these. So this is so timely that we have this Stomach Cancer Prevention and Early Detection Act, because it does actually focus on identifying the high-risk U.S. populations, improving data on the gastric cancer incidence and disparities, and supporting research on prevention and early detection, and increasing awareness. So I only have like about less than 2 minutes, so we don't really have the population-based guideline. I know certainly if you ask me a question, do you suggest then people age 40 and 50 above should be screened endoscopically for gastric cancer in the U.S.? My answer is no. It shouldn't be, not for general population. But for high-risk population, we should really seriously think about that. But we don't really have a lot of data to suggest that. So I think we need the 3 sets of data that we need to go forward with the screening recommendation. The first one is something that I showed you earlier, the age-specific instance of gastric cancer. And that's certainly one type of data we need, because that shows the threshold age when we can start screening gastric cancer, in what population. The second is the detection yield studies, basically asking is the screening worthwhile? So that will involve, for example, how many endoscopies do we have to do to find one cancer? So we don't have a study on that. We have a couple of collaborators actually who are actually coming tomorrow, one of them who will speak on this as well, and then we are about to conduct a study on that. And the third important study will be the outcome study, looking into the mortality data and the cost effectiveness data. We don't have that. So we have a tremendous lack of data, and this is, I think, why we need the advocacy to ask for all these, and not only for more research support, but also increased awareness on these important issues of stomach cancers. So you can find my final slide. There's an opportunity for prevention. Many high-risk individuals remain under-recognized. Most stomach cancers in the U.S. are diagnosed late. Prevention strategies are there, but I think we need to identify the high-risk populations and bring the prevention to them. Thank you very much.
Thank you once again, Doctor. I would like to invite Dr. Davis and Dr. Laliotis up to the front to join for Q&A, please.
Oh, it does work. Don't everybody stand up all at once. Oh, please. You see it right there? He's bringing the microphone.
I have a question. I did not have a lot of the risk factors, like I didn't have H. pylori or anything. I'm curious, is there any talk out there about people who have had gastric bypasses and getting some more screening for us? Because I had to fight tooth and nail to get screened and to get diagnosed. It took a lot to get someone who was able to do a double balloon endoscopy on Oahu, because I come from Hawaii and I don't have any like gastric oncology specialists or anything there. So I had to push. I think they tried 3 times before they finally found a doctor who was able to, I call it backing into the garage, because that's what they kind of had to do to find my cancer. So I'm just curious as if anybody's kind of looking at people who've had this weight loss surgery as a risk factor too. Just curious.
Yeah, I'm not aware of anybody studying it specifically as a risk factor, but certainly having had Roux-en-Y gastric bypass makes it really hard to do any kind of surveillance. The stomach remnant ends up being kind of a black box, and that's a huge challenge. But in terms of it being a risk factor, I'm not aware of anybody doing research in that space, although I think you guys are going to see that weight loss or bariatric surgery and all that is going to shift dramatically now with some of these drugs on the market that are kind of, way easier than surgery.
That's true. Thank you very much.
Thank you. With myself having this type of cancer, and you were saying that maybe we could test high risk like in the family, would it benefit me to have my son say go to his doctor to say my father has cancer? Can you test me for the H. pylori or that type of gene?
Well, okay, so for the H. pylori thing, H. pylori is acquired in the environment, and people probably acquire it very early in life, right? So getting screened for H. pylori, if you have a family member, a close family member who's had it and an associated cancer, is probably something that would be fine to talk about with their doctor. If you're talking about other kinds of testing, though, especially genetic testing, that's a whole nother kind of conversation, which we can certainly address too, because those are the kinds of questions that people oftentimes come to their doctors with is, hey, a family member of mine just got diagnosed with stomach cancer. What do I need to do? Right? That's probably along, yeah.
I just want to know what he has to go say to his, he's in the military, but I want him to tell his doctors what I'm going to do.
Yeah, great, thank you. So, as we said, the H. pylori is kind of a, it's a completely different thing. So for genetic testing, this is again kind of a gray area, as we said, because it depends on the variant of the gene. So for example, if someone has like a BRCA1 or a major gene, then yes, the family has to be tested. But if it's kind of a variant of unknown significance or something that has not been tested, then it's kind of a gray zone, because we basically, yes, you can be tested, but we don't really know what to actually do with it. So this is, again, this goes back to the principle, yes, have a discussion, ask, discuss with genetic counselors, people that they go very, very deep on this. But, that would be kind of be curious, ask questions, and, just take it from there.
Thank you. So a couple things from the medical oncologist perspective. I think we are pretty aware that, right, there's data that eradicating H. pylori also reduces the risk of other GI cancers throughout the GI tract, right? But my bigger question is, so I'm all about this screening and eradication, but in those patients who are noted to be positive, knowing that it induces, right, a BRCA-like state in the cell, essentially, that's what has been documented, and that means that there's probably a long-term deficiency in DNA repair that may occur even after eradication. What do you think about, like, in the patients who are deemed positive, even if you eradicate, do you think those patients need tighter screening protocols going forward for the rest of their lives? For not just stomach cancer, but potentially even other luminal cancers?
Well, currently, those who are, eradicated, there isn't really any other follow-up on those patients. We don't really have, not that I know of, any current, recommendations or anything like that. So, but it's very important to confirm eradication, that's for sure. But once that is done, I mean, the chance of a reinfection is very small, so we really don't need to keep checking,
I don't mean sorry to interrupt you. Yeah. I don't mean that we should keep checking for H. pylori. I mean that it's possible that there's already cellular damage that's occurred in clones within the GI tract, right? So should we be screening those patients more tightly even after eradication for GI cancer in the future? I guess it's maybe more of a question for the medical oncologist than, right, because I understand that the risk is reduced, but then in the long term, is their risk still, is it normalized, or is it still higher than the general population?
So this is what it is. If you look at, for example, what we call the Korea cascade, we're talking the H. pylori, the cancer, this is the carcinogenesis on gastric cancer. The gastric cancer doesn't take place overnight. It goes through the many stages. So if you look at in one end here with normal gastric mucosa, where, for example, with infection and or environmental factors such as, for example, nitrate and salt and etc., which will eventually cause the chronic inflammation. And after decades of chronic inflammation, tissue can develop intestinal metaplasia and gastric atrophy. And after years of that, it can develop dysplasia and the cancer. So those who have H. pylori infection, many of those people, I would actually recommend scoping them, because there is a chance that they may have intestinal metaplasia and or atrophy, which are pre-malignant conditions to gastric cancer. And we do actually have recommendations for surveillance of those people every 3 years for gastric cancer. So I think that for that reason, I think I would like to scope some patients in order to determine if they have gastric intestinal metaplasia and or atrophy.
So it's only if you find those lesions on endoscopy that then you encourage future tighter screening or more frequent screening protocols. Okay, understood.
Hi, I'd like to find out, because here in the United States, you have colonoscopy for gentlemen 45 and above. Why can't they just add the endoscopy, which is a 5-minute procedure? I know that because I was an endoscopy nurse. And one of our members here at Hope, he was getting his routine screening until a family member suggested, why don't you just add the EGD? Well, lo and behold, they convinced the endoscopist to do that, and they found early stage of stomach cancer. And he's NED now, but that was, happenstance, if not for that routine colonoscopy.
Yeah, I mean, that's a very important. We do actually have a cost effectiveness data on that. There was a study published several years ago which showed that if we do add endoscopy, upper endoscopy, for those who are undergoing colonoscopy at age 45 or 50, it makes sense in high-risk populations, not for general populations. Now, but again, the question, the data that we really lack currently is how many of these cases we have to do to find one cancer. You know what I mean? So that study has not been done. In fact, I have a surgical oncology fellow, colleague from Rutgers who is actually coming tomorrow as one of our speakers tomorrow. And she, we're trying to do study on that actually. So that's a possibility.
We met through endoscopists because City of Hope has a satellite now in Irvine, California, and majority of the population there are Asian Americans.
Right.
And I believe they are in the step towards getting a baseline EGD for those high-risk populations, which means whether or not you have GI symptoms, they will have that.
Yeah,
EGD.
Yeah.
I wish it can be adopted nationwide.
Yeah, I think there are a lot of people who are pushing for that.
Yes.
The thing is that I haven't shown those data, but in Korea and Japan, for example, they do screening starting age 40 biannually, every other year with endoscopy. As a result of doing that for past 20 years, the mortality data is strong. They've decreased the mortality by more than 50%.
And I think that's what we want here as well.
Yeah, and the 5-year survival rate, for example, in South Korea is about 75%.
Wow.
75%. So, but that's because it is a high incidence country. Here in the U.S., it's a low incidence country, but we have to respect the heterogeneity of the population. So it's a little tricky situation. We cannot recommend, population-based screening. That we cannot do. But for certain, risk populations, I think we may consider doing that. But I want to say that there's a very famous study from 1960s, actually, in the Japanese Issei and Nisei study, where actually, if you look at the gastric cancer incidence in Japan, Japanese Japan, and then Japanese in Hawaii in the first generation, and the second generation, the incidence of gastric cancer actually goes down, but never converged to that of the average non-Hispanic white, for example. But it goes down substantially, but it's still high. But it's not as high as what we see in Japan. And it's just very similarly, I have the data that actually currently being reviewed in one of the journals that talks about this, and Chinese, Koreans, and Vietnamese, and Japanese, same thing. It's coming down. But it all depends on the age of immigration and the life course exposure that he or she had, back in their native country. So this is very, very complicated.
Well, just don't forget. It doesn't matter sometimes if we recommend that people get stuff done. Because then people have to get it done. And we've had colon cancer screening guidelines in the United States for a very long time, okay? And it only recently went down to age 45, right? For the longest time it was 50, okay? My uncle got diagnosed with colon cancer at the age of 60. He never had a screening colonoscopy at the age of 50, right? So I think, yes, the first step is to talk about who do you screen, how often do you screen, all that stuff. But then once you put that out there, people actually have to do it too. And how many of us put off getting stuff done? Cost, insurance, right? So these are all things also that have to be factored into it, which is why, one of the reasons why people on the basic science side of things or the translational research side of things are looking at ways to make it easier. Can we, right? That's why you have Cologuard, right? So I'd rather, have to submit a stool sample than get a colonoscopy, right? So it's also, can we find better ways to do the screening? Because invasive thing, even x-rays, mammograms, I mean, how many women really enjoy going to get that mammogram? I mean, yeah, you want a pancake with that? I mean, so right? Can we find better ways? Somebody way in the back, buddy. He's getting his exercise.
Hi. My father got diagnosed with stage 4 gastric cancer, and he tested negative for H. pylori. The following month, I had my mom tested for H. pylori, and she was positive. So is there any possibility that he had H. pylori and he was so advanced in his cancer that it wasn't detected?
Entirely possible, because it's entirely possible. Yeah, because your father might have had H. pylori infection in the past and got treated. Maybe.
But he never got treated for it. I mean, he never.
Well, I mean, a lot of people, for example, take antibiotics for after dental procedures, so on. They're not the most effective treatments, but those can sometimes, get rid of eradicate the bacteria. I mean, that's not the most effective, but I don't recommend it. But I think we have to think of that possibility. So, but you know what? H. pylori, he did not have to have H. pylori to have a gastric cancer.
No, I understand that. But I just find it strange that my parents have been together since they were 14, and my mom tested positive, and they're together all the time.
Oh, well, we see many families like that. Yeah, I mean, we checked that this, one spouse doesn't have it, the husband has it, wife doesn't have it, wife has it, husband doesn't have it. Many cases like that. Yep.
Thank you.
Hello, I wanted to know, I know this may be a pathology question, but I'm just curious rather, are there any studies that show patients who did have EGD and were completely clear, no signs of any type of dysplasia or precancerous conditions, then having a EGD maybe 2 or 3 years later and having stage 4 disease? So I'm just wondering if there's any testing or any knowledge as to how fast it grows, or has anyone seen the time frame between having nothing and then having advanced disease?
Okay, so I'm going to take this real quick because we've got 3 minutes left. I'm not a pathologist, but that's my side hustle. But the point is, it's not a pathology question, right? It's a what's the sensitivity of an endoscopy, and most endoscopies that are done for screening for symptoms like reflux or heartburn or whatever, they don't, it's a quick endoscopy, 10 minutes, 15 minutes, you're done, you're in and you're out. You're looking for major things. Subtle things can be missed, right? And we know this from our colonoscopy literature, right? If the colonoscopy is not done in a certain time frame, right, that you can miss precancerous lesions, right, if it's done too quickly. So I think the short answer is that it's an issue with the test, right? Any test that we do, whether it's a CT scan, a chest X-ray, a blood test, whatever, has to do with sensitivity, right? How good is that test at identifying something when something is in fact there? Okay, so that's number one. Then the other one is that most cancers take years and years and years to develop. Okay, we know this from breast cancer, colon cancer. So it's very possible that somebody has an endoscopy, that nothing obvious is seen. Doesn't mean that nothing is there. It just means that they didn't see it. Okay, maybe it was too early, too subtle. And then 3 years later it was there. And that's just because it does take years and years for things to develop, and unfortunately not all tests are perfect, right? And we know this, you guys know this around PET scans and other kinds of scans. They're just not perfect. And so this is a challenge when we're trying to create any kind of test.
You know, I want to add something to this, is that there is a tremendous variability between the endoscopists, especially in the United States. And this is one of the things that we do in our program to teach fellows and the young gastroenterologists how to evaluate endoscopically how to do this thoroughly and accurately. And the experience that we have in the U.S. with upper endoscopy is relatively poor. So, you know, if, for example, in Japan and Korea, or certain centers actually, and including ours, when we scope patients, we systematically biopsy throughout the colon. I mean, throughout the stomach. You know, when we screen, you know,
But that's screening.
usually.
That's
Yeah.
screening.
Yeah.
But that may be different than an endoscopy.
That's
based
a
on
screening.
symptom.
Even for symptom, not only biopsy or not biopsying it, but actually visualization is totally different. You have a lot. I found out that a lot of endoscopists do not differentiate normal from intestinal metaplasia and from atrophy. But you should be able to see that with your bare eyes. Enough to you know, signal that this needs to be biopsied. But a lot of them don't see the difference. Especially the differences are very fine. So I think I want to emphasize, because this is one important aspect that we try to do with our society, Gastroenterology Society, to how we can upgrade and how can teach you know, fellows and young physicians how, you know, how to do this more skillfully. There's a serious problem with that. So that could explain that partially, maybe. Yeah.
Thank you, doctors. For the sake of time, we are actually going to take 20 minutes to stretch our legs, have some coffee. There are some snacks in the next room over. And then we're going to head back over here for the last 2 sessions of our breakout before dinner at 6 p.m. Thank you guys for everything.
Wait, Aaron, which way do you want us to stand?
I need to update my picture.
You need to update your picture? Oh.
Priscilla, you want one?
Oh, there we go. Do I look good?
Yes, you do. Yeah. Nice smile. Laura wants to MSK.
That name doesn't sound familiar. I don't know all of them. I just know a few. So I know a few surgical people, and that's how I get access to the other people. Like when I'm putting statisticians out there, I'll just call my buddy who's a surgeon. And I'll say,
Where is he going to be? Is he going to be here?
yeah, because I don't know any of this people, but I have these surgical friends, and that's how I get my references. That's how I know. Why is that? Stuff like that. Well, you know what you do? You know what you should do is, so what you do is you probably try to go to something like this. Like, can we have a little symposium? Can we have like a little, like a half day kind of, CMS luncheon or kind of events, And sometimes what that does is that'll get them realizing that there's people that are interested in this or whatever. That's what I would do, And then, or you say, hey, and I recommend that you invite somebody to come in and talk about whatever. And then they just do it. Usually they have, they usually have to do it, right? But I think you just have, you find an ally there. You might find a greater ally on if you've been, like, let's say they don't do it from that on. People, avoid them, but the GI people, whatever, and just find like an ally. Actually, the incoming chair of surgery there. She's coming from Michigan, and she's going to run the whole department of surgery at AU. They're bringing a lot of cancer research effort, and so it'll be really awesome. Yeah. But they're investing, I know they're investing a lot of money. So the person who's coming in to chair the part of surgery, I know they're investing a lot of money in not just surgery, but in cancer research in general. So you may see that over the next year or two. It's really going to take shape. My understanding from talking about things about that. That's what I heard. Yeah. You'll get there. And again, you just have to find the right allies. Like sometimes people, it's just not the right fit. It's either not their jam, or whatever. And that's fine. You're like, okay, you want a partner? Fine, I'll find somebody else who wants to partner. But I know there's some good people there in surgery, and I know the one coming. And I think that'll have, a lot of times they'll have like influence. They have like this person's coming and they want to do X, Y, Z. It's everybody else. Okay? Great to see you. I'm so excited to see a lot of familiar faces. Yeah. You're right. Now I'm going to go home. I know.
So you stood here and I'm not. Oh, you are? Okay. Are you GI
think I saw his post about her, and then there was one day that everyone dressed up as George, and I think she was the one who like started
Yeah,
it.
she like organized it.
Yes,
to join
yeah.
the
We worked together in Modern Jones' office.
Okay, so, oh, hi Nicholas, how are you? I'm Rebecca. When you come up here, there should be, and you could remove your badges, there should be like the clicker, large green circular button. Angelica, your presentation is going to be here, and you both have a timer countdown right there.
Great. Oh, is this the green?
Yep. Yeah, try it. Perfect. And now keep going. There you go.
Is the timer for the whole session?
Nope, for each of you.
Okay.
So Angelica's going to speak, and then you're going to get introduced, and then you're okay. Okay. Go back one more. There you go. Thank you.
Wait, is Priscilla?
She's going to
introduce us, so we'll just hang out here.
Yeah, that's fine.
Okay, I'll get more water.
If you have any questions, please have them raise their hands, and the microphone will be brought to you. Especially since we're actually still live streaming, so but we also don't want to see people here.
Oh, I'll get off.
How long has the question session been going today?
It depends. If you go long, I'm gonna cut you off because you were in between. I mean, no one having snacks. Yeah. Yeah, but you were the bill. You're the bill. So we really need to get that across as we go into dinner, and we have a whole birthday dinner tonight. As you being the bill, it's like really like this is what you are going to speak tomorrow. Right. This is what Hope is putting up. This is why. This is the bill. So it's really like.
Right.
It's the bill and the approach language.
Yep.
Okay.
Yeah.
No,
maybe not.
Yeah, I was like, I wasn't told about.
No,
they just
maybe
asked me to talk about the
Sorry, just the bill.
The approach language isn't happening anymore? Okay.
But what is the bill? What are they talking about? Highlights.
Yeah.
Just those highlights,
Yeah,
those points.
yeah.
They're going to meet tomorrow with their representatives. What? Like, let's do that.
Is there approach language in their ass?
I have no idea.
It's the CDMRP approach language for stomach cancer research. It was a bunch of the stomach cancer groups were signed on to it, including Hope is one of the endorsing organizations.
Yeah, but that's not their bill. Their bill is an actual prevention action.
Oh, I just want the appropriations.
No idea.
Funding for research.
No idea. I don't know if that's on. You have to go ask them to do that.
Yeah, I don't think I've met her.
There's Aki. That was the fastest way for me to find her. You know how hot it's been in here? It's either hot or I do nothing. It's either going to get boiling hot because it's playing on
I mean, lower the AC just a little bit.
You know, every time I've asked that, then it's turned into super hot.
They only have 1 more hour of sauna. It's so cold.
But honestly, by the time it gets hot, we're going to be like, I will try. And we're going over.
We got some.
Okay, I didn't try this one, but we were just going over specifics from Nicholas on the bill, and Angelica was asking about the
Appropriations language for research for cancer, the CDMRP letter. CDMR.
the word that you help from all
Stomach cancer groups.
Yeah.
Yeah. Yeah, and then my organization also works for water.
Is that the study?
Yes, the research study.
I mean, I think it's worth because some of these people advocated on the Hill for Livestream like 2 weeks ago. So it might be worth like touch upon it, but I don't want to do this because they will be tapped. That's what Megan told me. You know Megan in Livestream?
No.
I don't know
because that was we just signed, it was just signed off on that appropriation, but the type sheet there, that's what it is. And then this is Brad Fitch, who will be speaking about how to navigate Congress during dinner. I'll bring it in.
Nice to meet you too, Brad. Hi. Dick, nice to meet you.
Dick is with the Fang Group, and Angelica with ACG.
American Health and Gastric.
Okay.
Funny enough, we both used to work together at Saving Children.
Oh, really?
For that area.
Oh, yeah.
Okay, great. So what? So when I get up there, just let me know when you want me to join.
Oh, yeah, I'll give you like 5 minutes. I just shut these off for now. But, oh, are you?
We're right here. I think we're talking. Yeah, here's more part. Yeah, this is what the folder is. And like I mentioned, mine will go a little quick, so I'll also hang out if there's Q&A for Nick and I too. I worked on the bill, and then I've been a staffer. Nick and I were, you did more lobbying at Save the Children than I did.
Yeah, we're coworkers.
Oh, really? Yeah, yeah. It's a small world. I guess we're in DC, so.
What do you guys feel about like drop-offs?
I always tell my members, ask for 5 minutes with health shop when you're dropping something off. Don't ever just leave it. And even if you can't talk to health shop or talk to staff assistant, make sure you're getting FaceTime. You're getting voices right. Yeah, I can mention that.
I'll work with Brad to add in his thing too.
The lobbying 101.
Yeah, but like you just, the more these are like single brain people, so the more you
Yeah.
get them.
Yeah, I have, at the end, I have a Q&A, and I have like prompts of like things you can ask, you know, as performers, health staffer.
Okay.
Yeah, no, I understand.
Because we're really only doing, we really want to get this pushed, and I think this is it, right?
Yeah.
We want to get it introduced in the Senate, in the Republicans, and yeah. So much. Yeah, I think 5 more minutes.
Yeah. Something that you should mention that's not on here is the meeting offices. Just have to ask which office are looking in. Yeah, they should know. Wilson is leading my approach letter. I got our approach letter actually for the science here. Other questions that come up, is there a CBO report, is there a score? No, score. No, but that's just questions that we have. Wow. I'll do a little bit of Q&A.
Yeah. Well, because you're talking all the time.
Well, if there's any way I can be helpful to whatever is being asked, because I've talked about this here a few times. Chrissy got demoted.
But that's just me. You know me. I'm kind of bossy.
Oh yeah, Jeremy. Okay, I see his name right here. Okay. Wasn't she?
I was sitting there because she was sitting there. You had to fight with her feet. You have to fight with her legs to get in through. She's like right where the camera is.
But it's not like a C-suite.
If it was just me,
I was the one who I was expecting it to be.
It actually got colder when we were out. It was cold when we left. I think it's actually colder now.
I'm trying to be stuttering up there. Well, that's what I'm saying.
I turned mine off. I was like, okay, this is perfect. That's like not too cold, not too warm.
Well, it's hot and it's cold.
And I've been going a lot more.
Rebecca scares me, but I'll go tell her.
Tell her again.
Like, suck it up. We have one more session.
She goes thinking McDonald's.
I love like just cold enough days and nice warm blanket. And I go right when my
I got a 7, 8, like that. 7's a weekday. 8 is night, really.
Well, this is me in my younger years when I actually had hair that wasn't gray. That actually does. You can get over that.
Good afternoon. My name is Priscilla Brittine. I'll be sharing a little bit of my story with you. The first time that stomach cancer came into my life was with my mom. She was 42 years old, and I was 14 when I lost my mom. And losing my mom at such a young age, really, it was an awful feeling. Won't ever forget that. So about 15 years later, I found out that my family carried a genetic mutation, and it was CDH1. Between that time I lost my mom and 2018, we lost 7 family members, all from stomach cancer. So it wiped part of my family. We have a big family, but literally wiped them out. Some of them I did not know. So I went to go get tested, and I was positive for CDH1. And prophylactically removed my stomach, at least I was thinking. And it came back a week later. Stomach got sent off to get biopsied. Came back. I had stomach cancer. So I'm glad I did what I did when I did it. And now I have 3 boys. And hopefully I will be their support and help them through this. I've got a 20-year-old that will be tested pretty soon. And I'll be there for him. And you all will have their support, and you will be there for them too. I know you guys will.
To finish our afternoon of Policy in Action, we are now joined by Angelica Duque, who will be talking with us about how clinical updates are driving policy. Angelica is the Manager of Government Relations at the American College of Gastroenterology. ACG represents over 20,000 gastroenterologists and advanced practice practitioners across the country with the aim of advancing digestive health and improving patient outcomes. In this role, she leads congressional health policies, advocacy efforts, expands relationships with stakeholders. She previously worked on Capitol Hill for 5 years and covered policy portfolios that included health, education, immigration, and defense issues. Please welcome Angelica.
Thank you so much, Priscilla, for sharing your powerful story. So I'm here to talk to you today about how clinical evidence can inform congressional engagement and the relationship between medical societies like ACG and patient advocates like yourself. So here's a little bit of our outline. We'll do introductions, then we'll go into advocacy issues and go over 2 case studies examples, and then at the end I'll have some Q&A. Like Priscilla mentioned, the American College of Gastroenterology has the goal of advancing digestive health and improving patient outcomes. We represent over 20,000 physicians and advanced practice practitioners across the country, and many of our members are also researchers, but most of them are practicing clinicians. I worked on Capitol Hill for 5 years in the Missouri, California, and New York delegations. I met with many groups like yours, so I'm also happy to talk at the end about some tips and advice. And in this role, I look at what different priorities that ACG may have. So we kind of break it down to 3 different areas. So we talk about conditions and also patient advocacy issues. One of the bills that Nick will talk to you about is the Stomach Cancer Prevention and Early Detection Act. Met with many offices about the bill. We also focus on colorectal cancer issues and a few other more specific patient advocacy issues like celiac. There's one bill that talks about including celiac as one of the main allergen factors. So definitely a lot of GI issues that come across our bench and that we try to advocate on. So for workforce, there's a Spark Act. It's to make sure that there are specialty physicians in rural areas, and then also another one on physician shortages and try to get more residency spots in hospitals. So we also look at practice issues on prior authorization. I'm sure many of you have gone through prior authorization issues of trying to get the medication that you need, and it takes time from you receiving exactly what you need, and it takes time for the doctor meeting with you and actually doing their work. Another issue on telehealth. And I really want to talk about the relationship between patient advocacy groups like yours and medical societies. There are so many ways that we, interact together. There have been a couple of patients in the meetings that some of my doctor members have had in congressional offices. Now, you all have an advantage that medical societies don't. You all can own the issues, and you're empowered to talk about them. You all are constituents and voters. Offices would rather hear from you than from lobbyists like me. PAC money is great, but it's really voters and constituents like yourselves that matter. You're also a subject matter expert on the issue. Physicians can be, but you all can talk about how your condition has affected your daily lives and how you all are dealing with the issues or have dealt with the issues. You can put the bill into real life stories and connect using your powerful stories. Hill offices are not going to get that type of meeting with other groups. You can describe to Hill staff what everyday life is like, lifestyle, diet, challenges, and costs. These stories always seem to resonate well. You all are passionate about your issues. Otherwise, you would not travel all the way here to DC. And you can continue your advocacy back home. You can visit your state and district offices, attend town hall events. You can look for local opportunities to engage and to be seen and heard. And I really want you to remember that these meetings are just the start of your process with political engagement. It's just one step. Your goal here is to get really great relationships with the staff, to remember you, to sign on to your ask. And like, again, you all are the subject matter experts, your constituents. I hope you have that confidence when you go into your meetings. So I want to talk about one issue that ACG has really championed these past couple of years on surveillance colonoscopy. In the prior session, we talked about, colorectal cancer. 45 is the new 50. Screening age was dropped in 2015 from age 50 to age 45 after there were overall increases in colorectal cancer rates, and a few of our clinicians and researchers started to see these trends emerge to the point where the Multi-Society Task Force, which is where all the GI societies come together, and decided to drop that screening age. So again, the clinical guidelines also study the effect of surveillance colonoscopy. And sorry, I got a little bit ahead of myself, but for those of you who haven't had your colonoscopy yet, once you get it, if your physician, your gastroenterologist finds polyps, they're removed. And if there aren't any polyps found, you come in at 10 years. And that follow-up colonoscopy is called a surveillance colonoscopy. Let's say they are found. Depending on your doctor's suggestion, you should come in at 3, 5, 7 years, much earlier than 10. When colorectal cancer is detected, or when polyps are detected early during colonoscopies, during screenings, survivability rate for colorectal cancer is around 90%. When it's caught at stage 3 or 4, it drops down to 12%. It's one of the steepest declines for cancer. Our governors, which are leaders, every state has 1 or 2 ACG governors, what we call them, have heard from insurance companies not classifying colonoscopy as surveillance colonoscopy as preventative care. Right now, your initial colonoscopy is covered, but these follow-up surveillance colonoscopies aren't under most ACA plans and private employer-sponsored plans. They are completely covered under Medicare, so there's a lot of discrepancy. I'm sure many of you have seen in the news the new recent statistics from the American Cancer Society. Colorectal cancer is now the leading cause of cancer death for men and women under 50. It was on track to be, by 2030, the number 1 cause of cancer death for men and women under 50. We've hit that statistic back in 2023. So it's coming up in younger and younger populations. So this is the population group that's going to need those follow-up colonoscopies, and not just, it's great that we have them for the 65 plus, but if it's happening younger and younger, then we're going to need a lot more follow-up colonoscopies, which aren't being covered, unfortunately. So this issue had been flagged to us by our doctors, patients. We heard a lot of patient stories where a doctor said, you should really come in at 5 years. Patient waited too long because it's not considered preventative care, so they have to go through prior authorization. They have to pay out-of-pocket costs. It's just really hard to have someone drive you for your colonoscopy, or to get maybe that bowel prep isn't covered because it's not considered a preventative service. There were just a lot of issues that were preventing people from getting screened. And again, colorectal cancer is one of 2 cancers that are entirely preventable. It's that and cervical cancer. So we used a lot of these stories in our meetings to, go to Congressional office and say, like, hey, I had a patient who should have come in earlier. Now it's too late. Now we're treating. We would rather prevent than treat. We have had many meetings. We had meetings with the first Trump administration, with the Biden administration. Now we're trying to get into this newer Trump administration. It hasn't been easy. Hopefully this won't get too wonky, but every year Congress has to pass a funding bill. That's why you sometimes hear we're in a shutdown. So fiscal year 25 and 26, we got our report language, which just means that the committee finds that this issue is really important, and that's passed into law. So it kind of gets a little bit complicated, but it just shows that Congress agrees that this is a really important issue. Now this year we're trying to get, so it was included in fiscal year 26, really great news. This is the first time it had ever been included. So this year we're asking for report language again, but we're having a letter that members of Congress will sign on to. Again, it can be a little complicated, but we just want a list of members saying, okay, we have X members supporting this issue. We know we have champions. We know we can go to these offices. And this year, we're also asking for a report back from CMS, from HHS, so they can tell us exactly how many plans cover this, because we have no idea how many ACA plans cover surveillance colonoscopy as preventative care. We have no idea. Seems like the number is very little, but we can't say for certain. So that's what I do as a lobbyist. I mentioned I worked on Capitol Hill for a few years. I covered health policy, and there was one time I had a meeting with an advocacy group just like yours. They were paramedics from Kansas City. They talked about their experience with frequent flyers. So frequent flyers, I don't know, by a show of hands, do any of you watch the show The Pit? Yeah, okay, I'm obsessed with it. We should see more hands next year, but it's a great show. So you're here, like frequent flyers, people who call 911 and say, I need a bed lift, or I, have a headache, or, whatever issues they may have. When paramedics transport them, or actually they don't get transported, they're treated at home. Paramedics don't get paid unless they're transported. So a lot of these folks were also showing up to the ER because they wanted care, they were lonely, or they had small issues, and it was eating up a big part of emergency departments and also ambulance costs. In some departments, it was somewhere like 20 or 30 of their operating costs. So they created this program called Community Paramedicine, where they would go out, these paramedics would go out and treat people, give them diabetic wound care, help them with their lifts, treat them where they were, instead of having them show up in the emergency rooms or not getting paid because they wouldn't bring them back to the hospital. So I thought, well, this is a really great program. I asked them where they received their funding. They told me they had local, county, state sources, but no federal funding. So as a staffer, I had like a light bulb turn on. I thought, well, okay, why don't we create a bill that would fund community paramedicine programs across the country? This would be a federally funded bill. We would have a pilot program because once these programs started, emergency rooms would see huge savings that would then get lower costs for the hospital systems. And in the Kansas City area, this program started in kind of in the rural area. So this bill was really, really helpful to rural communities. The paramedics then connected me with their lobbyists and large organization who helped me find a co-lead, a Republican co-lead. I worked in a Democratic office. I met with other stakeholders, other paramedics, emergency doctors organizations, any patient advocacy groups for certain conditions. They either reached out to me or I reached out to them. And then this bill was finally introduced with several endorsements. The congressman also went back to the district, visited the paramedics that first, sparked this idea. So what I want to show you is that, you'll have these meetings, you'll talk about your bill, but I hope you can really have those engaging conversations. When I was a staffer, especially during spring, I would have really short 15-minute meetings because I would have 6, 8 a day. This is the busiest time on the Hill. So when you're talking to these offices, ask the staff you're meeting with, are you from this state? Are you from this town? Oh, me too. Or did you go to school there? Just start with a hi, hello conversation just to start that engagement. And if you notice, oh my gosh, this meeting's only been 10, 15 minutes, try to drag it out a little bit. Ask them, what are you working on? What are your boss's priorities? Do you know, or at the beginning, do you know anyone with cancer? Oh, well, let me tell you about my story. You really want to try to engage your staff. I can't remember how many groups I met with, but there were a couple that stood out because of their stories, because how they actually tried to talk to me like I was a person, not try to talk at me. I know I look young, but I was younger on the Hill, and there were a couple of people who talked down to me because they thought I didn't know anything. So also the folks who treated me with respect, that also stood out to me. But yeah, just really try to make those connections because that is what a win can look like, having a connection with the staff or following up. Oh, next time please let me know next time you're visiting. I'd love to introduce you to my cancer support group, or I'd love to show you around where I received my treatment. There are a lot of connections that could be made in these meetings. So that went kind of fast, but open to Q&A if you have any questions about, the role of medical societies, talking about patient relationships, any experience on the Hill. I know you'll get to that, but like I mentioned, I'd previously worked on the Hill and rather recently as well. I was actually just on the Hill last week with Fight Colorectal Cancer. Was on the Hill last month with Beyond Celiac, a celiac group. So, yeah, happy to chat about anything. No questions? Okay, thank you. And then.
Should celiac patients be biopsied every so often since they can turn into cancer?
Yeah, unfortunately, I am a lobbyist and a doctor, so I can't really answer that or give medical advice. But just to plug in my organization, if you are looking for a new gastroenterologist, you can go to giat.org and look for gastroenterologists. And on the ECG website, there are also a lot of patient resources. I know some of you were talking about no longer having stomachs. There are like ostomy resources as well and other types of resources there. Yeah.
Thank you, Angelica, for highlighting how clinical updates are driving policy, helping bridge the gap between scientific discovery and real-world care. To conclude our policy and action portion of the afternoon, we are now joined by Nicholas Kishaba, who is going to be speaking to us about Stomach Cancer Prevention and Early Detection Act. Nicholas is a public policy professional with a proven track record of shaping legislation and a dynamic approach to government relations. He specializes in appropriations, health policy, and group roots. Advocacy brings strategic insight and creativity to his work. Before joining the Ving Group, Nicholas managed Save the Children's appropriations and health policy portfolios, leading lobbying efforts on over 20 accounts. His advocacy secured the inclusion of over a dozen pieces of report languages in enacted appropriations bills. Additionally, he successfully coordinated grassroots campaigns that helped secure over $9 million in supplemental humanitarian aid. Please welcome Nicholas.
Thank you. And thanks to Hope for Stomach Cancer for having me here today. Excited to talk with you all today. So like she mentioned, my name is Nicholas Kishaba. I'm a senior associate at the Vang Group. It's a full-service public affairs consulting firm. I primarily work with small to mid-sized nonprofit organizations on government affairs, which is DC lingo to say I'm a lobbyist. To just dive right into the bill itself. So it's called the Stomach Cancer Prevention and Early Detection Act. It is, the bill number, if you're curious, is HR 4841. It was introduced last August, August 2025. It had a previous introduction in a previous Congress, but didn't end up getting passed, so we had to reintroduce it last year. It's a bipartisan bill, so it was introduced by one Democrat and one Republican. It was introduced by Judy Chu, a Democrat from California, and Joe Wilson, a Republican from South Carolina. Just to go over really briefly what the bill does, I know federal legislation tends to have like a reputation for being, really lengthy, jargony, difficult to read, just kind of overall hard to understand. But luckily, this one's pretty simple. Actually, it's only 6 pages. If you'd like to read it, you can go on Congress.gov and actually read it, and it's very simple. Basically, what it does is it directs the National Cancer Institute to conduct a comprehensive review of stomach cancer in the U.S. and then give a report that just recommends how to improve prevention, early detection, and ultimately treatment. That's all it does. It doesn't ask, it doesn't create any new programs. It doesn't create any new mandates or requirements for insurance. It doesn't cost any money, which is kind of why it's such an easy ask for you all tomorrow. You're not asking Congress to spend any money. You're just saying hey, let's focus in a little bit more on this issue. And for a little bit more detail, the areas that the bill really asks the National Cancer Institute to review current incidence rate, risk factors, optimal age to test and treat for H. pylori bacteria, trends among screenings such as availability, effectiveness, and then just kind of giving an overview of what the current federal efforts are to increase awareness and education of stomach cancer. That final report, like I mentioned, would define high-risk populations. So we would have a real federal definition of who is at risk of stomach cancer. It would give recommendations for improving early detection, especially among those high-risk populations. It would give guidelines for establishing routine screenings. And then it would give recommendations on actions to improve research on prevention, diagnosis, and treatment. There's also a military component, which I will touch on a little bit later. You don't really need to worry about this. The military component is primarily so that we have an opportunity to get this bill into the National Defense Authorization Act. But just for your awareness, so you know this, it requires a separate study that does the same thing, but on active military members and veterans. If you are a member of the military or a veteran, then I think feel free to loop this into your personal story when you're speaking to members or their staff. But like I said, it's really part of the congressional strategy we have around it. So with that kind of background, can I pause for questions if anybody just has wants some questions about how the bill works and what it does? Anything? Cool, that's great. Okay, good to know. I did great. So really why this bill matters and what you should be focusing on. I'm not going to throw numbers at you guys because frankly, staff don't want to hear numbers. They can Google numbers. There's going to be numbers in these leave behind packets you have. If you just regurgitating numbers isn't really helpful in these meetings. You should really be talking about your own experience. So as everybody here knows, stomach cancer is diagnosed too late. The 5-year survival rate drops dramatically when it's detected at a late stage. And so this bill really focuses in on just how to address that. Like I said, does not ask for money. So what you should focus on when you're talking, tell your personal story, right? If there's anything from this sort of review that they're asking for that you think could have helped you or a family member or a friend, talk about that, right? If you think an earlier screening or a treatment for H. pylori or some sort of step in early detection would have helped you, a friend, or a family member, talk about that. Bring that up in your conversations and bring up how meaningful and impactful it would be if there were better guidelines for medical professionals to treat this. Focus in on how early detection saves lives. Really talk about that because that's what this bill does. It asks for recommendations on how to detect stomach cancer sooner. And then finally, it's office to office. Some offices like certain talking points, but frankly, it's smart, cost-effective policy. Like I said, we aren't asking them to spend money. We're not asking them to create a new program in the federal government. We're not changing the Affordable Care Act. There's nothing crazy about this. We're just simply asking them to take a little bit of a closer look at stomach cancer and give Congress just a little bit of data-backed evidence to address the issue. And now where this bill is going and where this all plays into it. So like I mentioned earlier, our goal is to get this bill into the National Defense Authorization Act. You don't need to know about that bill. It's just the bill that kind of does everything, tells our military where to spend money. But it's a great vehicle bill. So you can stick a lot of stuff in there that, maybe is only somewhat relevant. And for this one, it's about a third of the bill is relevant to the military. But the end is all the same, right? If it gets included in this and it gets passed, suddenly the National Cancer Institute has to give Congress what they just asked for, which I just described. And then ultimately, like I said, it doesn't ask them to spend money, but it's a stepping stone. The National Cancer Institute already looks at stomach cancer, but this is explicit instructions and just an expression of concern from Congress that stomach cancer is an issue, and if we can get this report back, it's hard evidence that we can bring to Congress so that they can actually move towards solutions to improve outcomes for stomach cancer patients. So I kind of sped through that in about 7 minutes so that we would have time for questions. But that's really the whole bill overview and what you should be talking about as you do your meetings. Questions? We can start in the back.
Could you say a little bit more about why this won't cost any money and why we're not asking to throw a little bit of money at NCI to do this work? Because even if federal staff are doing this review, that takes dollars.
Oh. Yeah, so not to kind of get into the nitty-gritty of government funding, but reports like this are basically looped into what we would call operating expenses for different agencies. So the National Cancer Institute, I don't know the number off the top of my head, but they have a certain amount of money allocated every year to just exist, keep the lights on, pay their staff, et cetera. And they have staff specifically for stomach cancer and research. And so a review of this is basically an internal review, and it's kind of looped into that operating expenses. Why we wouldn't ask for money off the bat is basically because it's controversial and hard without evidence from, evidence from them first. So right now, in general, I would temper expectations on the bill because less than 5 to 10% of bills introduced get passed. Bills that include money, it's even harder. And so while you might not be able to get a bill passed that costs money right now, if you get a report from the National Cancer Institute that gives a recommendation, and part of that recommendation includes something that would cost money, now you have a recommendation from the federal government that was congressionally mandated, and you can take that to Congress and say, like, hey, we actually do need to spend more money. And so, like I said, this bill is like is a stepping stone and a larger strategy to address the issue, but it's a really important stepping stone. There's another question. Yeah, thank you.
I just wanted you to repeat the bill number, if you would.
Yes. Oh, yeah, of course.
Please.
And it'll be in your leave behind packet too, but it's HR 4841.
Thank you.
I was going to ask, since you guys are familiar with working on the Hill, when people like us go into our personal story, how much do you want to hear? You want to hear like a minute segment, or,
I'll have Angelica answer.
Did you already
that.
say that? Maybe I was too cold to hear it.
When you go into your meeting, give a small talk. Sometimes just ask, hey, how much time do we have? If it's 30 minutes, then you can go a little bit long, but make sure to, I'm sure you'll do this in your next session. Think of a story arc, like, this is how I first got diagnosed. This is what happened to me, and now this is why this issue is important. I've had meetings where people talked way too long about their details and sometimes got a little gory that I checked out. So just kind of have an arc, a pitch, kind of like an elevator pitch, and try to make sure that you're hitting the details on like why is this important. And when you do that small talk of like, oh, do you know someone with cancer? You can maybe say like, oh, like your grandmother, I went through this, or like your father, I also had that. So when you're connecting, that can add to it. But when like I mentioned, I would do 15-minute meetings so I can meet more with groups. I just kind of wanted the top line things, but again, try to connect, like, oh, I went to this cancer center that is in their district. If you have multiple people in your group, maybe you can select 1 or 2 people to give their story, just so there aren't 3 different similar-ish stories. Yeah, I hope that answers your question.
Just for our information, because we're going to be talking about the NDAA, can you tell us about the evolution? I mean, I'm looking at this one, and I know that it was introduced 4th
for NCI, right? For NCI to conduct it. How did this come about, and how are we going to impact more on language, if ever?
Yeah, so I think first and foremost, I wouldn't worry about the NDAA. The ask isn't to ask them to put it in the NDAA. That has to be done by a specific committee. But the goal is to get as many people supporting, as many members of Congress supporting it as possible. Because when it comes to timeline-wise, the NDAA is typically passed late summer, maybe early fall, depending on the year. But when they go through and start piecing together this big bill, different offices can submit things to be added to it. And if this is like a broadly supported bipartisan bill, we have a really high chance of it getting support, like getting actually put into the bill when it comes down to passage. She was on the origin of the bill, so I think she might be helpful with like the original stuff.
Yeah, so my organization, American College of Gastroenterology, helped develop the bill in the last Congress. So it was Congressman Caraveo. She was a doctor. She's no longer in office, so I got handed over to Judy Chu. So my boss worked directly on the bill. The reason why there's the NDA element is because the Republican co-lead, Joe Wilson, for many years, he had led an initiative to specifically target current active military populations in stomach cancer, because a lot of them have to travel abroad and they, interact with H. pylori. So that's why that piece is in there, because they wanted, Caraveo's office wanted this bill to be bipartisan. So talked to Joe Wilson, who had an interest in this issue, and said, hey, let's partner on this. We'll add your military piece. We'll keep this piece that I had worked on, and now the bill is bipartisan. And it's also just a great issue, like Nick mentioned, of maybe we can put this in the larger NDAA bill when you're speaking, especially to a lot of Republican offices or Democratic offices too, where maybe that member serves on a committee that's tied to the military, like armed services or veterans. They look at this and are like, okay, this is something my boss supports. I really like this piece. So it's just to have kind of a larger coalition of interest.
Yeah, but like I mentioned, like when you're speaking about the bill, you should really be talking about your personal story. So if it's relevant, bring it up and talk about the military connection. But I think it's like 2/3 of the bill is mostly other stuff. So it's not a big deal if you don't want to, if you have no connection to it. Any other questions?
So I should preface this by saying this, I'm kind of ignorant of all the moving parts in federal government, but I was wondering if there's been any sort of relationship or attempts to establish a relationship with representatives of the NCI.
Sorry, like, have we worked with the NCI on what's in the bill, or?
Yeah, or are there any higher level representatives or employees that are in support of the bill? I don't know if you have an answer to that. I was just kind of curious.
Yeah, I mean, not explicitly. I'm sure there are people at the NCI who support it. Typically, federal employees don't express support for bills in the first place. In the past year, there's been kind of even less, like there's less people expressing support for anything or even speaking politically within the government. So I can pretty confidently say no, I don't think there's anybody at the NCI who said anything about this. Yeah. Any other questions? Great. Okay. Thank you, everyone.
Thank you, Nicholas. This now ends our live stream portion of the program. We thank all those that were able to join for this afternoon. For our final program of the evening, we will head to the reception hall for dinner to prepare for our Hill Day tomorrow. We'll be seated by home states. If you are not joining us tomorrow, we invite you to still come to dinner and sit with us. Thank you again.